Good morning. It is my pleasure to welcome Dr. Miller back to the Health Subcommittee to help us continue our discussion on payment reforms. Earlier this year, Congress took the first step in this area and passed legislation to fix the way Medicare pays our nation's physicians. We did so in a broad, bipartisan, bicameral way, and I was glad to see the President sign this important legislation into law. Well, now we need to take the next step, and that means looking at Medicare's acute care payment system. I want to raise the topic of site-neutral payment reforms. This is a policy MedPAC has highlighted for several years now. The President's most recent budget even included a site-neutral policy with respect to services provided in hospital outpatient departments. So this area of payment reform is not, or at least should not be, a new or contentious topic. This year's June report brings us new information and data that could help us elevate our discussion in this area. MedPAC has found that for some cases, we're paying as much as $4,000 more per case simply because there's a discrepancy regarding status. That is, was the patient supposed to be classified for inpatient status or outpatient status? Unfortunately, this is a real question the hospitals are faced with. But because the inpatient and the outpatient payment systems are so different, it's hard to get an accurate assessment of what's driving this trend. More to the point, the codes that are used to determine what Medicare should pay for inpatient services are entirely different from those used for outpatient services. Not only does this mean hospitals are responsible for managing two different billing systems, but it means Medicare has to do the same. And the issues with payment disparity become magnified when we consider that Medicare is expected to spend more than $130 billion on inpatient services and $40 billion more on outpatient services this year alone. Clearly, this is an area ripe for reform. MedPAC has proposed some innovative solutions. I look forward to hearing more today. Also, MedPAC's testimony focuses on indirect medical education and disproportionate share hospital payments, two add-on payments that certain hospitals receive to help offset the cost of teaching medical students or treating a larger volume of uninsured or underinsured patients. It's important to note that when we're talking about payment disparities between the inpatient and outpatient systems, that these two add-ons, IME and DISH, are only included on the inpatient side. Outpatient discharges aren't eligible to receive these payment adjustments. As a result, these important payments get caught up in a financial numbers game that end up driving incentives. I believe both of these programs are critical and need to be redesigned to deliver the most targeted payments possible. As arbitrary add-on payments, they're just not achieving their mission. As MedPAC notes in the June report, and as Medicare's own trustees tell us each year, the program is facing serious fiscal and demographic headwinds. Spending is out of control, and the current financial underpinnings will soon not be able to sustain the program for the long term. Congress needs to tackle these issues, and we need to tackle them now. We've already started down this path by successfully reforming how Medicare pays our local doctors. My hope is we can carry this progress over into other payment areas. With that, I'd like to introduce today's witness, Mark Miller, the Executive Director of the Medicare Payment Advisory Commission, known as MedPAC. And before I recognize our ranking member, Dr. McDermott, for the purpose of an opening statement, I ask unanimous consent that all members' written statements be included in the record. Without objection, so ordered. I now recognize our ranking member, Dr. McDermott, for his opening statement.
Thank you, Mr. Chairman, for holding this hearing today. I hope it will be a constructive conversation about how we can improve and strengthen Medicare. I'd like to thank our witness, Dr. Miller, for coming again today. We haven't seen you for a long time. We missed you, and we thought it's time to have a talk with you again. The work that MedPAC does makes an invaluable contribution, really, to the legislative process. We may not always agree with the Commission's recommendations, but we can trust that MedPAC's reports are based on the facts, data, and thoughtful analysis. Today's hearing is an excellent opportunity for the committee to carefully examine a number of issues that affect the future of the Medicare program. At the heart of the conversation must be the most important concern, that is making sure that beneficiaries continue to have access to affordable, high-quality care. Any proposals that we discuss here, I think, should be seen through that lens, and any changes that we have to make have to be in the best interests of the beneficiaries. Medicare is really about beneficiaries. It isn't about providers, it isn't about drug companies, it isn't about hospitals, it isn't about anybody else. It's really about beneficiaries. Medicare is a key component of the social safety net in the country, It provides core health care benefits to 54 million seniors and people with disabilities. And I hope this committee will join me in looking at ways to strengthen, not cut the program, to ensure that it remains strong in the future. If we're looking to achieve savings, the first place we should look is to make sure that payments are appropriate and accurate. We should proceed with caution before radically cutting payments at the expense of hospitals that serve the most vulnerable patients and the teaching hospitals that train the physician workforce. As we discuss potential policy issues today, it's important to remember that many are not formal recommendations by MedPAC. They are thought-provoking ideas that provide us with starting points for discussion. It is the role of the committee to carefully consider these ideas and ask tough questions about what they mean for Medicare and the beneficiaries. I'm hopeful that this hearing will serve an opportunity for us to highlight a transformation that is radically shaping the healthcare system and practice of medicine. Across the country at this moment, we are seeing a rapid and dramatic trend of hospitals merging together into massive health systems that exert tremendous market force. We count on our system to be working on the basis of competition, but it's increasingly questionable whether that occurs. We are witnessing hospitals purchasing small physicians' practices. As a consequence, more physicians are now hospital employees, something that was almost unthinkable when I went to medical school. This trend raises a question about the future of medical profession, healthcare spending, and patient care. As policymakers, our role is to ask these questions. The committee needs to hold a hearing on this issue and other topics related to healthcare consolidation. It's not a partisan issue, and I believe that we can work together to ask these questions and find out how to address this issue and move forward. And I hope this morning will be sort of a beginning, so welcome, Dr. Miller, to the committee.
Thank you. Thank you, Dr. McDermott, and thank you, Dr. Miller. You're now recognized for 5 minutes.
Chairman Brady, Ranking Member McDermott, distinguished committee members, I'm Mark Miller, Executive Director of the Medicare Payment Advisory Commission. On behalf of the commission, on behalf of the commissioners, I'd like to thank you for asking us to testify today. The Commission's work in all instances is guided by 3 principles: to assure that beneficiaries have access to high-quality, coordinated care, to protect taxpayer dollars, and to pay providers in a way to accomplish these goals. I'll start off today by reviewing some hospital trends. Hospital inpatient admissions are declining, both in Medicare and among the privately insured population. This has been a trend for several years now, and it's fueled in part by movement of surgery from the inpatient to the outpatient setting. In contrast, service volume in the outpatient setting has been increasing rapidly. For Medicare fee-for-service, the increase has been 33% over the last 7 years. While it varies by market, overall there appears to be excess inpatient capacity in the country. Hospital occupancy rates are around 60% and have been declining, and in rural areas the occupancy rates are around 40%. This is an issue that will drive change in the near term, regardless of whether a hospital is urban or rural. The focus of hospital care is changing from the inpatient setting to the outpatient setting. Another fact of life is that the hospital industry has been consolidating for several decades now. Again, it varies by market, but many hospitals have very strong bargaining positions relative to private insurers, and consequently private insurers pay hospitals well above their costs and much more than Medicare pays. On average, hospitals are paid 150% above their costs by private insurers. Our analysis has shown that these higher payment rates in turn results in higher costs. In other words, if a hospital is paid more by private insurers, all things considered, there are higher costs per admissions in that hospital. One other trend that I believe all of you are aware of is that there's been a lot of activity hospitals in purchasing physician practices. Some argue that this is to integrate and coordinate care. Others argue that this is to capture market share and increase revenue by obtaining higher outpatient hospital payment rates for office services. Perhaps the most concerning version of this is where a hospital purchases a physician practice in the community and then shifts the billing for those services from an office fee schedule to a hospital fee schedule. This means that insurers, private and Medicare, pay more, although very little has changed, and of course of most concern, the beneficiary has a higher copayment as a result of this. Turning to some of the Commission's recommendations, the Commission has recommended increasing Medicare's hospital payment rate, but coupled that with site-neutral payment reductions to remove some of the market distortions I just mentioned. To improve coordination, the Congress adopted the Commission's recommendation for a penalty on hospitals with excessive readmission rates. Readmission rates have fallen, but there is a further adjustment needed for hospitals that serve substantial numbers of the poor. The Commission recommended retargeting the excess indirect medical education add-on payment to hospitals and other entities that administer reform graduate medical education programs that focus on care coordination and provide training in alternative sites of care. The Institute of Medicine recently made a similar recommendation. Most recently, the Commission has made a series of recommendations regarding the recovery audit contractors to strike a balance between program integrity and administrative burden on hospitals. At the same time, the Commission made a set of recommendations to improve the protections for beneficiaries who are treated in observation status in the hospital. With respect to rural care, the Commission has made a number of recommendations that have resulted in higher payments for rural hospitals over the years. And as a result, the 900 rural PPS hospitals have higher margins than those for urban hospitals. And as you know, the remaining 1,300 rural critical access hospitals are paid on a cost basis. The Commission undertook a comprehensive review of access, quality, and payment between urban and rural areas in 2012. In general, the Commission found that urban and rural Medicare beneficiaries have similar levels of healthcare use, satisfaction, and quality, although there are some important differences that should be discussed if we get into that. More importantly, the Commission strongly believes that there is a need for supports in rural areas, but that these supports are often not well targeted or designed. One principle for reform that I will mention here is that support should be targeted to providers who have low patient volume and are thus unable to cover their fixed cost, but serve as a vital source of access, meaning that they are distant from other providers. To put it simply, in short, targets should support low-volume, isolated providers. In closing, I'd like to thank you for asking the Commission to testify today. I look forward to your questions.
Doctor, thank you very much. Clearly, our goal is to save Medicare for the long term. And to do that, we've got to get the incentives right, both for providing high-quality care to patients, affordability for our seniors, and to make sure this important program is around for a long time in the future. I found it striking that MedPAC concluded that Medicare paid roughly $4,240 more on average for an inpatient stay than for a comparable outpatient surgery. This sounds like a good place for Congress to start establishing site-neutral payment. I hope you agree with that belief.
It's certainly an area that should be looked at. It's one that we have begun to look at.
You know, focusing on just the 10 surgical DRGs or the procedures like MedPAC did, how difficult would it be for Congress to craft a site-neutral policy? And obviously what we're looking for is providing the appropriate care at the appropriate setting for the appropriate price and not creating incentives for people to get moved into higher cost procedures or areas when we could do it in a neutral approach.
I think that there is probably two ways to think about responding to that. One is whether there is the ability to kind of crosswalk between sets of services in the setting so that you could create relatively comparable classifications of services and actually focus on this is the service and set payments around that. And that, while it has a complexity to it, is probably something that could be done. And we could talk more about that.
And a crosswalk is what exactly?
So it was what you were saying in your opening statement. You were talking about the notion that there are different systems and different codes, and that's why I was trying to bring it back to that. There are different systems and different codes, but you can probably work, a crosswalk across that to begin to look at comparable, groupings of services or overlapping services. And the number that you're referring to in our report is a pass through, the top 10 medical and the top 10 surgical services where we tried to do that. But what I do also want to say, just by way of, caution, is what is more difficult to comment on is the actual structure of the policy. So if you try and say, I'm going to set up a site-neutral policy where you have some services paid outpatient, some inpatient, and then some paid site-neutral, that's certainly a goal that you can move towards. But what will be key is how services get in and out of those three systems, and how, in a sense, you police the borders, if you will, when a service gets into one setting versus another. And so that would be the kind of
Yeah.
issues that you'd have to think through, and not inadvertently create other incentives that drive services in one direction or another.
To sort of prove it out, the crosswalk we think is very important. We've gotten some pushback that that's difficult to do. I think, how difficult do you think it'd be for CMS if we focused on these 10, where you've identified them?
Yeah, and I don't want to toss this off as simple, but I decidedly think it's doable. These things, there are proprietary products that exist in nature. They do somewhat different things, so reasonable people can kind of end up with somewhat different categorizations, and so there's some issues there that need to be smoothed through. And probably what you want, if you were to ask CMS to do this, you would want, after they develop the crosswalk, you would want a clinical scrub to make sure that you have some coherency in the categories that you created from a clinician's point of view. Does this make sense to a physician,
Sure.
nurse practitioner, that type of thing? And then you put it out for notice and comment. But my sense is the intellectual technology to do the crosswalking exists.
Yeah. One of the areas of reforms, obviously inpatient, outpatient, are tremendously complicated. They're, in some senses, a demolition derby of reimbursements and incentives. The June report, again, looking at these surgical procedures, the June report mentioned really two approaches. One, the site-neutral payment for these surgeries could be carved out of the inpatient-outpatient system and moved into a separate one. Secondly, surgeries qualifying for site-neutral could be subsumed under the inpatient payment system. These are two approaches we ought to be looking at. We included one of them in our draft last November on hospital reforms. Can you lay out sort of for the subcommittee what you see the pros and cons of that? A separate system for those, or moving them under an inpatient?
Okay, so, and I want to just do one thing quickly before I answer your question. The way the commission went at this is we were responding to kind of the 2 midnight rule and a lot of the reaction to that, and a lot of concern on the part of the committees and so forth of what to do there. And the commission ended up making recommendations on RACs and beneficiary protections, and talked about the payment stuff, but have not made recommendations on that yet. So I want to be really clear. We're talking about ideas, not policies, and not recommendations. I think one thing to think through is the reason that you want to do these types of things is that your need for oversight, RAC types of overview, becomes less. To the extent that you make payments more comparable, there's less incentives to push a patient in one direction or another. So to the extent that you're setting out and saying, I want to set up payments so that this incentive is not so clear, that's one of the benefits of it. You're making decisions for clinical reasons as opposed to financial reasons, and you may not have to have so much oversight. The risk, and I've already said it, so I'll try and be very abbreviated, is how you set those boundaries and what services, whether the services are well defined or bluntly subject to gaming, depends on, that's the risk you run when you try and set something up like this. If you do it inside one of the existing systems, because your other question was, what if I did some site-neutral stuff inside inpatient, or I did some site-neutral stuff in kind of a standalone system? My sense is, particularly if you're talking about a small set of services or conditions or whatever we're talking about here, is you probably have less churning and change if you put it inside one of the existing systems. But I got to tell you, I'm talking right off the top of my head here. I'd have to want to think about this a lot more. Just saying that part.
Yep, good. Finished with this question. We talked about a bit, both in the opening statement and yours. There is a gradual migration of services from inpatient to outpatient. We need to recognize that. So we're concerned that this means for our mission-oriented policies and payments associated with that, such as indirect medical education and DISH, it has an impact. So our goal is to preserve and protect these funds. I'm concerned that they're not protected when they're so dependent on just one area, inpatient mission. One strategy I think Congress can pursue is reimburse indirect medical education and DISH in a lump sum payment rather than as per discharge add-on. So what do you think of this approach, how it might help preserve and protect IME and DISH goals?
I want to be really clear that this precise idea or this precise notion is not something that the commission has talked about. And at the end of my answer, I'm going to tell you one thing the commission has talked about. But to try and answer your question first, I think I understand your instinct. I think your instinct is what you're saying is if you're tied to inpatient and inpatient is going down, how do you preserve that? I think if that's what you're saying. And to the extent you were to capture that and assign that dollar to a hospital, in theory, movements in volume up or down or in or out would make that a more stable, regardless of movement, it would make that a more stable payment, all
Yep.
things considered. I would also think if you were to say that's the direction you would go, I'm sure the commission would also say you want to think about like maintenance of effort types of thing. If you get the block of dollars, you don't just back out of the
Yep.
teaching function and that type of thing. But I assume, you know, if you're thinking about these kinds of things, you would be thinking about that. Now, the one thing I do have to say is the commission went in a different direction on this and said there's $3.5 billion in direct medical education payments that are not well accounted for. And the commission said take that as a lump sum, but it was payable to hospitals or other entities that created these new programs. So in a sense, we went in a somewhat different direction here from your idea.
Well, I'm not so sure we aren't going in that direction
Well,
as well, to be honest.
well, that's
So, because I think we need a better view. One thing, this is a bipartisan issue. How do we make sure we have the right training for more doctors and future doctors? And we are intent on getting a much better insight in how all this is funded and the results of that funding going forward. So, Doctor, thank you very much, Dr. McDermott.
Thank you, Mr. Chairman. I read your report, and over half of it's drug policy. About 100 pages are.
June report, yeah.
And it's interesting, we're focusing on hospitals, because I think drugs, we recently passed a bill out of here called the 21st Century Cures Act, was passed out of the House. It didn't come through this commission, or this committee, but it had provision in there that gave incentives to hospitals for the overuse of newer antibiotics. And my question was, did they come to you and talk to you about that? Did the Energy and Commerce Committee come to you?
Not specifically that I remember.
It seems like it's going
I'm
to.
not sure I've got the provision well squared away in my head, just to be.
Well, they're saying use these new antibiotics as opposed to the traditional antibiotics. There'd be an incentive if you use the new antibiotics. Obviously more expensive and better for the pharmaceutical industry, but I'm not sure it doesn't drive up costs in hospitals.
And I'm just not wired enough on the specific
all right.
provision to help you. with
That's
this.
fair enough. The issue that got you here, that is the two-night, or the midnight, two-night, midnight business and all that, do you think you can find a site-neutral payment system that will not disadvantage the patients?
Just to kind of try and pick up the thread here in my own mind, you know, the commission approached the two midnight issue and ended up with its set of recommendations on RAC and beneficiaries, and ultimately didn't make recommendations on payment and didn't feel that there was a necessity at that moment to deal with you know, the RAC and the backlog issues through a payment change. Your question is a little bit different, perhaps, but can you create a site-neutral payment that is fair to the beneficiary? I think it's all in the design of the policy, so I would say it's possible. Not this site-neutral conversation, but the commission has made recommendations on other site-neutral policies between the physician setting and the outpatient setting. We actually think that helps the beneficiary because it keeps their co-payments down. In fact, it was one of the motivations for it. Now here, in this pushing together inpatient and outpatient, it would probably depend on what services and how you define the actual thing as to what the effect on the beneficiary's out-of-pocket would be. It would be very hard for me to comment without knowing the thing.
we're talking theoretically here, do you think you then can design a policy that a doctor and a hospital wouldn't look at and say, hey, let's do this because that will qualify us for this, which is a higher payment, than
So-
that which is not the higher payment?
And what I've tried to say and respond to a couple questions that have occurred so far is that's the trick is, right now there's an incentive between the inpatient and outpatient settings that look like this. And if I can get into the inpatient and I can keep the inpatient for one day, or keep the patient for one day, that's a very, or profitable transaction. I think
Let me stop you right there.
All right.
Okay, it's transaction good for the hospitals.
Yeah.
What about the beneficiary?
So it depends on whether the beneficiary, so generally, the beneficiary's out-of-pocket is less in outpatient than it is in inpatient. If you jump the inpatient wall, you pay $1,000, $1,200 deductible. If you're staying in the outpatient, in general, the beneficiary's liability is less. However, if it's surgery, it's actually not as much different. So it really kind of depends on, and this is why I'm saying, which services and what you do with them. And I think part of the reason the commission said, if you started thinking about thinking about site neutral here, you might start with thinking about surgery because the event is pretty definable. It's harder to game. And the differences in the co-payments may not be as much.
That you're talking therefore about a patient who comes in with what looks like appendicitis, and they put him in observation, and they ultimately wind up becoming an operation for a removal of the appendix. That's one kind, but the other kind of case would be somebody who has a little pain in their chest, and they put him in for observation, and they never graduate to full-fledged ICU or cardiac surgery or whatever.
And just to take that point and just put it a little bit differently.
Dr. Miller, could you do me a favor? Pull that microphone just a little closer. to
I'm
you,
really sorry.
if you don't mind. Thanks.
So nobody's heard anything I said up to this point? That's where we are.
I've been listening.
Okay. Okay. All right. So now I have no idea what's going on. So just to pick up on the thread of your question, I apologize. I didn't realize that was going on. One of the things that the commission did think about was whether we were talking about this kind of idea for medical or for surgical. And I'm not a physician, so I apologize for everything that's about to happen. For a medical condition, it's more complex to kind of follow what is going to happen. It can be more complex on what's going to happen with a patient. Your point, chest pain, I have heartburn, chest pain, I have a heart attack. These types of things can be relatively fluid, as opposed to surgery where the event and the procedure and the thing that is going to happen to the patient is more well-defined, and most of the cost is very present in that event. And I think that's why the commission thought, if you start someplace, start looking there. Does that answer your question, or am I, now you're sorry I moved this close to me, right?
Well, my feeling then is what happens to the patient at that point? Does he or she wind up more out of pocket?
And I think that really depends on the service, but in a surgical situation, and I don't want to speak too globally on this because the commission really sort of looked at this but didn't dive as deep on it. Generally between, for surgeries that tend to overlap settings, the beneficiary's liability is more comparable between the inpatient and outpatient setting than the liabilities for a medical procedure.
Can I have just a second to ask you unanimous consent to drop in a letter from the American Hospital Association dated July 22nd as their
Great,
testimony
without
for this
objection.
committee.
Thank you, Dr. McDermott. Mr. Johnson, you're recognized.
Thank you, Mr. Chairman. Mr. Miller, let me start by thanking you for testifying today. As you know, our nation has an incredibly complex hospital payment system with different coding classification systems and reimbursement systems, and where the procedure is performed. MedPAC concluded in its June report that because Medicare generally pays more for patients who receive similar services in inpatient settings compared with the outpatient setting, hospitals have a financial incentive to admit patients. To address the problem, MedPAC drafted a crosswalk to link 10 comparable inpatient and outpatient surgical codes. Such a crosswalk allowed MedPAC to compare these similar codes, which you then found resulted in inpatient surgical costs roughly 4,000 plus higher than for similar outpatient surgeries. I think it's an important step to ensure greater transparency in Medicare spending so we can ensure hospitals are not admitting patients solely for financial profit, but because it's medically necessary. So I'd like to take these moments to ask a couple of specifics. First, how important is it to have a crosswalk between similar surgical codes for inpatient and outpatient payment systems?
I think if the committee wants to pursue the idea that seems to be asking questions about site neutral, that type of thing, you have to have something like that.
Okay, how difficult was it for MedPAC to establish a crosswalk for these 10 surgical codes?
It was not simple, and I will just say again, I think reasonable people could come to different places in crosswalking individual codes from one location to the other, but I think there is probably a manageable process that people could go through to come to a crosswalk that would generally be viewed as acceptable. You would want a clinical, as I said, overlay after you did those crosswalks to make sure you were doing things in a clinically rational way. I would say that.
Well, thanks. And finally, in your opinion, is this something CMS could pursue in the future?
I do. I think I'm sure they would prefer to speak for themselves, but you know, my sense is that they could engage through a contracting process with firms that exist that do this, bring something in that would be used for public use. They would have to work with it both mechanically and clinically, as I said, because I don't think these things are just off the shelf, everything's perfect, that they would have, and they would want to put it out for notice and comment, get people, the hospitals, physicians, beneficiaries, everybody to comment on it. But I do think it's a process that they could pursue.
Everything's off the shelf, just like this hearing.
Yeah, right.
Thank you, sir. I appreciate your opinion, and I appreciate your help in that issue.
Right.
Thank you.
Gentleman yields back. Mr. Kine from Wisconsin is recognized for 5 minutes.
Thank you, Mr. Chairman. Dr. Miller, thank you for being here. I usually ask you a quick question about rural hospital reimbursements. In your 2013 your recent report, you indicated in 2013 the overall margin rate for rural hospitals about 0.2%. But also in the report, you acknowledged that a large part of that margin was based on the HIT incentive programs that have been going to rural hospitals. That now is being phased out. So is MedPAC taking into consideration the phase out of the HIT incentive program and what that's going to do to margins for rurals? Because 40% of them are operating in negative margin territory already.
I think the answer to that is yes. The commission, and one thing, and it went by really fast in my opening statement, so I'll just say it again. We have made for the last few years positive Medicare payment increases for hospitals. We recognize that rural hospitals are about at 0.2, but let's just call it 0. Overall margins are negative for hospitals in Medicare, and consequently the commission has, among other reasons, the commission has made recommendations for payment updates for rural and urban hospitals. So,
Okay.
and in thinking through those issues, we take into account things like your exactly what you're asking. What's going to happen to this? What's going to happen to that? We look forward and
Okay,
do
very
all of
good.
that.
Let me shift gears. Obviously, CMS has been pushing the metal a little bit hard now on changing the payment system, going to more value and outcome-based payment model. You undoubtedly, and MedPAC undoubtedly, has been watching this very closely. I want to get your impressions on how that's going and whether there are some additional areas of acceleration when it comes to value-based payment models, especially in the post-acute care area where I think there's some substantial savings that can be had and while also increasing the quality of care.
So we're not talking about hospitals or rural necessarily.
No, we've
we're
moved on
talking
to
bigger.
totally different payment question here.
Okay, I'm going to start, but if I don't have the right question here, just redirect. So if you're talking about kind of large, payment delivery reform types of things like accountable care organizations and
Right.
that type of thing. So what I would say is, coming out of the health reform legislation, so there were things like the readmissions penalty, which I know is not particularly popular, but has actually had the effect of reducing readmissions. And just by the way, the commission has some ideas to address hospitals that deal with disproportionate shares of the poor that we could talk about if anybody wants. Moving on from that, ACOs, I think the analysis we've done there suggests that ACOs are producing small savings, 1Z and 2Z percent types, and it's in parts of the country where fee-for-service tends to be high, which if you think about it for 30 seconds kind of makes sense. On the bundling and post-acute care, there hasn't, there's that demonstration. I don't want to make a global statement. I don't think this is a commission statement, but there hasn't been a lot to show there yet that I've seen. And I think there's some concern on the part of the commission that, lots of people wanted the data, a lot fewer people wanted to take risk, and to the extent they wanted to take risk, they wanted to do it for only a few services. And so getting a lot of traction in the post-acute care, say through a bundling strategy, I don't see a lot of it yet, and I'm worried that what's out there isn't going to necessarily
Well,
produce
Mr. Brady and I have been working on some proposals, and undoubtedly would like to follow up with you and others at MedPAC for some advice
Okay.
or guidance as we get ready to move forward on that.
Okay.
Great, thank you.
Gentleman yields back. I was next in line, so maybe I'll let the chair take over here, and then I'll assume my rightful position.
So Dr. Price declined to recognize Dr. Price? Is that the case? Thank you for letting me step out from it. Dr. Price, you're recognized.
It was this perspective that I
you're
designed.
craving. Okay.
Welcome back.
It's good to see you.
Thanks for coming. And I appreciate your qualification on as a surgeon on your definition or your description of the difference between medical observation and surgical observation, and we'll have a conversation about that offline.
Okay.
I have a number of questions I want to raise. First is on meaningful use in electronic health records. In a 2012 MedPAC report, MedPAC commented on talking about the decreased uptake of utilization by physicians of EHRs. And I've been surprised that in the last 3 reports, or last 3 years, MedPAC hasn't addressed the issue of meaningful use in EHRs. Is there a reason for that? Do you plan on addressing this issue that is so incredibly important for
We
for
can
docs?
certainly dive back into it. We're a small operation. We can't cover the waterfront every year all day, and so we tend to focus on things and then move to other issues. But if there's an interest in it, we can certainly try and look back into it.
Let me just share with you, I spent a couple hours this past Monday night in Atlanta with a group of 80 to 100 physicians on the specific issue of meaningful use and the incredible challenges that they're having in their practice, caring for their patients, decreasing productivity, increasing costs, decreasing access to care from the patient standpoint. And so I would urge MedPAC to take another look at it, especially in view of the fact that it appears that CMS is forging forward with Stage 3 without regard to any information or statistics, real metrics that demonstrate that Stage 2 has actually been a success. Let me shift to site-neutral payments, and I appreciate MedPAC's perspective on this and the push that you all have made. I think it's an incredibly important issue. And I'm curious as to whether or not you believe that CMS could go ahead and do site-neutral payments right now without Congress acting.
Without Congress acting. I don't know the answer to your question off the top of my head, not in any real significant way, at least that we've been thinking about it. The recommendations we've made, and I think some of the discussion here, although I'd really have to think about it, would require more changes in law, but I'm not 100% sure. It would depend on what you meant by site neutral, I suppose.
well, especially outpatient surgical procedures and what I think are significantly increased costs to the system, yes, but also, as Dr. McDermott has pointed out, to the patient as well in terms of copays and deductibles on things as insignificant as minor procedures, but as significant as major procedures like joint replacements, which are now being done as in an outpatient setting in many instances. So I would.
And I want to think about the answer to your question, because depending on if it's done inside an existing system, I wonder what flexibility the secretary would have. So I want to withdraw a little bit.
Great.
And think about it.
I'd love to.
Yeah, I
to
don't
get more
know the
information.
answer to your question.
In-office ancillary services exception, the GAO reported in multiple studies from between 2004 and 2010 that they didn't uncover any evidence at all that suggested that it would be appropriate to repeal the in-office ancillary exception. Milliman did a study that showed that costs in the hospital were greater than costs in the office. JAMA has done a recent report that demonstrated the same. Can you opine as to, or can you share with us what information you've provided to CMS as it relates to this, or opine as to why you believe HHS or the administration seems to be incentivizing a move toward hospitalization as opposed to utilizing services in hospitals as opposed to the office for these kinds of procedures and examinations?
Yeah, I'm just gonna. You tell me if I'm off base. I'm not. I don't feel so much that people are actively trying to incent the move from office to hospital. Although you may be aware of something I'm not. More, the way I think about the issue is historically, private and Medicare created payment systems to pay for hospital care and physician care. Hospitals is no mystery. Hospitals are more expensive.
Yes.
And a big argument is why and what people should pay for and all of that. And so you end up with payment systems for comparable services that look like this. And then hospitals have started to purchase physician practices and then just shift the billings from one setting to the other. More what I see as that motivation is that there's a financial signal out there and people have begun to pick up on it and are moving in that direction. And our recommendations on site neutral, and I think what was included in the president's budget, although I don't have that wired in my head, were to try and do a bit more of leveling that out.
Correct.
So that incentive didn't exist as strongly.
Correct. Did that mean my time's up, or that I've got a minute?
I'm sorry
Yes, sir.
about that.
Thank
I didn't
you
mean-
both very
I
much.
look forward to getting back with you, Dr. Miller.
Yeah, sorry for going on.
Mr. Pasco, you're recognized.
Thank you, Mr. Chairman, and thank you, Dr. Miller, for your service. I'd like to discuss with you graduate medical education. In my home state of New Jersey, there's 42 hospitals maintaining residency programs. That number is increasing. I'm proud that our hospitals are at the forefront of training the next generation of physicians. I know you're very interested in that.
Commission is, yeah.
Despite the fact that our teaching hospitals churn out many highly trained physicians every year, New Jersey faces a physician shortage. My state's challenge retaining physicians in New Jersey after they complete their residencies is a big problem. But many of the states that my colleagues here today represent actually benefit from this problem. States like Pennsylvania and Delaware with lower costs of living benefit from residency programs that New Jersey hospitals undertake. When physicians complete their residencies, they move out of the state. A few months back, I met with a family physician who completed his residency in New Jersey and then moved to Texas to practice where the cost of living is much lower. Given the shortage in the physician workforce pipeline, impending physician retirements, the aging of the baby boomer population, and a number of other issues, we need to be growing the number of Medicare-supported residency positions, not reducing them. The landscape of how we deliver health care is changing. The Affordable Care Act laid the foundation for moving away from a fee-for-service model towards quality-based payment. quality-based payment systems. Congress could take one step further by repealing the sustainable growth rate earlier this year. That's what we did. One of the issues MedPAC has highlighted in the past is the role that GME funds and teaching hospitals can play in preparing new physicians to practice in a quality-based health system. One fact, one of our hospitals in North Jersey, Hackensack Medical Center, has an extremely successful accountable care organization. They've adopted their GME program to promote this integrated care model. Now, Dr. Miller, can you talk a little bit about how teaching hospitals can leverage their position training the next generation of physicians to underscore the importance of quality-driven healthcare, care coordination, and a team-based approach to healthcare, which we talk about all the time, but this is going on in places throughout the United States. Would you respond to that?
I think so. So the commission did some work back several years now, and as I mentioned quickly in my opening statement, I think the IOM has more recently said some very similar things. And what the commission said is we took a look at curriculums, and we're concerned that in the residency trainings there was not focus on team-based care, using evidence-based metrics to guide care, using EHR, the stuff that you think about in a reformed delivery system. And what we said was there should be a set of criteria, and given time, I won't drive you through it. There should be a process that includes many stakeholders, which I won't drive you through. It's all written down in the report, to come to this more comprehensive look at graduate training to drive towards delivery reform, that to have physicians and other health professionals who are versed in these skill sets, as well as training in alternative settings. Physicians see a lot of patients in nursing homes, offices, clinics, urban, rural, and to drive in that direction. And then attach the GME dollar to the programs that meet that criteria. They could be hospitals, and to the extent that the hospital example you said is driving in that direction, at least in the commission's point of view, that's what we would be looking for.
Well, then let me ask this final question, Dr. Miller. If you say, and I believe you believe in what you said, wouldn't it be an incremental increase in those residency positions help states like New Jersey? Well,
we were so close, but the commission does not agree with that. And
why not?
And I'll tell you, the commission's view was simply expanding the number of slots is going to produce more of what we have, and it's not necessarily going to keep residents in your states. They can still leave.
Right.
And so I think there was some concern that without a much more rigorous look at changing the graduate medical education strategy and what is needed, we shouldn't just simply increase the number of slots.
Well, Mr. Chairman, I have a great deal of respect for Dr. Miller, as you know.
But you disagree.
But through the chair, I'd like to get a more definitive answer to the question. We don't have the time right now. With your help, I think we can.
Be glad to. And just
Thanks.
so you know, we're going to be holding a hearing dealing with GME and sort of get deeper into this subject because it is a bipartisan
In the
issue
fall?
going forward. Yeah.
Okay, thank you.
And I want you to know that if you'd like us to come to your office and you or your staff and just take you through all of it,
Yeah, I
we're
think that'd be a good idea, too.
more than happy to do that.
Thank you.
Yeah.
Appreciate it.
Thank you, Mr. Smith, Dr. Smith. You're recognized for 5 minutes.
I thought physicians were leaving rural America for urban America, but I hear otherwise. So obviously I represent a rural constituency, and there are many challenges, and I talk to providers, and especially in rural areas where the support staff is probably not what it is in urban areas. I'm not complaining about that, but the recovery audit contractor issue has had a significant impact, and it just has frustrated a lot of providers. So I had a bill last Congress which would have reformed the RACs, and I'm continuing to work on this issue. But I was wondering, now the commission made several recommendations for the RAC program. Can you touch on those recommendations perhaps, and maybe give a brief rationale for each one? I don't want to put you on the spot, but if you do have those handy.
No, I do have handy. This was in our most recent report. I figured it would come up at some point. So with respect, just focusing on the RACs, and we also made recommendations on beneficiary protections, but just on the RACs, we basically said three things. That instead of the RAC review being very comprehensive and hitting all kinds of hospitals, focus the RAC efforts on hospitals that have aberrant patterns of one-day stays. And so in a sense, it's targeting. Number two, RACs are a contingency fee type of operation, and we want the RACs to bring the most credible and defensible cases, not just sort of, to take their chances and do as much as possible and then see what happens. And so we would say the contingency fee should in part be adjusted if they have poor overturn rates. They bring lots of cases that get overturned, then their contingency fee should be brought down, make it a financial incentive to bring good, strong cases. The third thing is to adjust the look-back period for the RAC. So RACs were able to go back several years on hospitals and say, I'm challenging this particular admission. And, 2-3 years, a lot of administrative costs trying to dig that out, electronic record. And it may be past the point that if the claim was denied, the hospital couldn't bill for a set of outpatient services that they did provide. So you might say, well, this inpatient was unnecessary, but they did provide some outpatient services coming in the door, if you will. And so we said that should be better aligned so that the hospital has the ability to make this calculus. I can defend this case, and so I'm going to appeal. Or actually, I'm not so sure I can defend it, so I'm not going to appeal it. I'm going to actually just take the lower outpatient reimbursement and walk away. And that's the dynamic, rather than appealing everything or appealing nothing, that we're trying to get set up in there. So
Okay.
those were the three RAC things.
Sure, I appreciate that. Shifting gears here just a bit, I represent a number of critical access hospitals. Some are, they're all rural. Some of those are actually remote. And I know that you've previously said that the closing of rural hospitals is proportionate to the closure of urban hospitals. Is that an accurate description? I would say that the impact to the community and perhaps to the patients themselves is disproportionate. Does the commission take that into consideration at all?
Yes, and by saying it's proportionate, I don't think anybody was trying to say, and this drives right to a point that I would like to make. You may agree or not, but it does. The commission, in writing that down on paper and reporting what's happening, we weren't trying to say, and therefore there's no issue here. Obviously, if you're in a urban area and a hospital closes and there's two other hospitals right nearby, the significance of that closure is very different than if you're the only hospital within 50 miles. And the thing that we're trying to say is rural, and this comes from our rural commissioners. First of all, think of rural this way. There's rural as in 50 miles from any other provider on a hilltop, and there's rural adjacent to an MSA. You're right across the border from, a metropolitan statistical area. The access implications of closure in those two settings are very different.
Right.
You might have to travel somewhat further into the MSA, but you still have access to something. And so the point that I think the commission has been driving at for several years is think about the supports that go out to rural areas, and what you want is to really support that isolated, low-volume provider, because they can't ever be expected to cover their costs. They're too small. There's not enough admissions that roll through or outpatient visits to cover their costs, and there's no other alternative. But all over the place, we are
Please finish.
I think I'm done.
By the way, no other witness ever stops when I do that, so I appreciate that very much. But this important point.
But I am going to finish. It's very, very short. A lot of our current supports for rural areas kind of make it critical to the community to hang on to their hospital, even if that hospital is close to another hospital. And they both have low volume, and bluntly, they are more likely to have low quality. Whereas if there was a consolidation, they might be economically more viable and might even improve quality there.
Thank you.
Sorry
Good.
about
Thank you,
that.
Doctor, and thank you, Mr. Smith. Mr. Davis, you're recognized.
Thank you. Thank you very much, Mr. Chairman. Thank you, Mr. Miller. Illinois' 7th Congressional District, which I represent, contained the most hospital beds of any congressional district in the nation. In addition to that, we're home to 4 major academic medical centers. According to the new workforce projections, the nation's face a shortage of between 46,000 and 90,000 physicians by 2025, with shortages most acute in surgical specialties, the result of a growing aging population and the newly insured, which tend to need more specialized care, especially the elderly who live in longer. Medical schools have increased enrollment, and teaching hospitals are expanding training to address physician shortage. Medical schools and teaching hospitals are also working hard to ensure that new doctors coming into the system are trained to serve in new delivery models that focus on care coordination and quality improvement. I'm concerned that reductions to Medicare graduate medical education would harm teaching hospitals' ability to effectively train the number of physicians we need in the future, and would adversely impact access to care for both the elderly and the newly insured. My question is, while Congress seeks to reform Medicare payment to graduate medical education, shouldn't we also be making sure, or trying to make sure, that we're able to meet the projected need as we continue towards 2025?
I think the answer to that is yes. I think a couple things I would say with absolute respect, and I don't know the source of your numbers, but I would say depending on who's doing the projecting, you can get very different kinds of numbers of what's shortage and what isn't shortage. There are also people in the academic community who have less of a stake in this and have looked at this and have argued that it's not so much aggregate supply as distribution problems, and have suggested also changes about which level of physician versus a nurse practitioner versus a PA that could, for example, to fill some of the needs. What I would say directly to your points are, one question is given the dollars that go to support slots, the commission could think about which of those specialties are likely to either be in short supply or are less lucrative for the hospitals to support, and shift the given dollar to support those kinds of training programs. So some interns and residents are very valuable to the hospital, and they'll support them even without a subsidy. Others are less valuable to the hospital, and they are less likely to support them. So you could think of, given a dollar, how you distribute that dollar. A second thing I want to say is the commission did not ultimately reduce indirect medical education. It did redirect how it was, it went to the various programs, and that's what I was saying in response to the question before you.
Well, let me ask you a little bit about site-neutral payment policies. Do you see this adversely affecting teaching hospitals and disproportionate share hospitals, perhaps more than others, because of the clientele?
I definitely see where you're going, and the commission contemplated this. And so I'm just going to blow past this part. It depends on what kind of site neutral you're talking about. It'll affect different hospitals differently. But let's just say, for the purposes of your question, some site neutral policy has an effect on a hospital that serves a disproportionate number of poor folks. The commission said you could mitigate that, the effect of the policy, by looking at what the amount of poor people, say, that a hospital serves. They actually directly contemplated policy designs that would try and address that problem.
Thank you very much. I know that time is a factor, but I'd like to discuss these issues with you further if we get an opportunity to do so.
As always, we're happy to brief you and your, or your staff, whichever way you'd like to go.
Thank you very much. Thank you, Mr. Chairman.
Thank you. Mr. Marchant, you're recognized.
Thank you, Mr. Chairman. I'd like to pick up where Chairman Brady was talking at the very beginning. The Affordable Care Act splits the DHS funds into two pots. 75% of the dollars go into a pot that's being reduced every year, and the other 25%, which is sometimes referred to as the empirically justified pot, is not being reduced. It is my understanding that MedPAC came up with this notion of empirically justified. Can you explain how MedPAC got to that classification and their reasoning behind it?
I can, and I think you're clear in your mind. I just want to be clear in everyone else's mind. We didn't come up with this system that you're referring to, the two parts, but we did come up with the empirically justified notion. So this is work, and this is way back now, but this is work when we were thinking about the indirect medical education add-on payment and the disproportionate share add-on payment. And here's a way to understand it. It's a little bit technical, but I can do it, I think, very simply. Here's a hospital's cost per case. And thinking about what drives that cost per case, it might be more complex patients in one hospital or another, or differences in wages from one area to another, or something like that. And so you can see that cost go up and down based on what's happening in a given hospital. There are add-ons for IME and, your question, disproportionate share, and the rationale for it has changed depending over time and who you're talking to, but one way to think about it was supposed to help hospitals that served disproportionate shares of the poor, and the thought was serving poor folks increased the cost for the hospital. And so if you run that analysis, which I can take you through in detail, but for this conversation, if you run that analysis, it says that's true, but it's this much more, and the adjustment is this much more. So the adjustment overachieved, if you will, and gave the hospitals more than their cost increase. And we just went through the analysis and said the adjustment actually, should be smaller than it is. And we actually didn't even make a recommendation. We just analytically went through it and said this adjuster is set too high.
Is it your opinion that the DHS money is going to the hospitals with the greatest need?
All right. I know you think this is a yes or no question, but let me say it this way. If you think it is about poor Medicare patients, the answer is no, because the DSH adjuster contemplates poor Medicare patients and Medicaid. If you think it's about supporting poor Medicare and hospitals that get lots of Medicaid patients, it's probably tracking that. If you think it's about uncompensated care, it's not tracking that. So it depends on what you think.
Next question may help
Sorry.
you with that.
All right.
I'm particularly interested in the hospitals in the state of Texas. As you may be aware, Texas is not a Medicaid expansion state. So it's my understanding that the DHS formula is based in part on Medicaid days for a hospital.
It is.
Is it possible that in addition to losing money on the Medicaid DHS side, Texas hospitals are also losing money on the Medicare DHS side because of how the formula is calculated?
It is correct that if you have more Medicaid patients moving through your hospital, your DSH will be higher.
So in a state that didn't expand, it's arguable that your volume is not what it would be in a neighboring state that had a similar situation that had expanded.
I think factually that is a true statement.
So I have 6 hospitals that have contacted me that I believe they feel like that their funding has been affected by the fact that Texas is not an expansion state based on the formula.
I don't think the fact set is wrong. without making a judgment about what people want to do. I think the fact set is correct. If you have more Medicaid patients moving through your hospital, your dish payments will be higher.
So we're preparing some legislation that we'll present to the committee to try to rectify this. Thank you.
Thank you. Mr. Oskam, you recognized for 5 minutes.
Thank you, Mr. Chairman. Dr. Miller, thanks for your time. My question has to do with some of the work that the Oversight Subcommittee has done at Ways and Means, particularly in the looking at fraud and improper payments. So a few months ago, we had the individual who's in charge of anti-fraud efforts at CMS before the subcommittee, and we posed a simple question to them, and the question was, what's your fraud and improper payments rate? And they said it was 12.7%, which is a number that is so big it just takes your breath away. Now, just for the sake of creating a sense of wonder, we had the person who's in charge of anti-fraud efforts at Visa, the credit card people, ask them the same question. His answer was on $10 trillion worth of global transactions, their fraud rate is 0.06%. So this cavernous difference just really does take your breath away. There's a lot of discussion about how it is that we're going to make sure that the trust fund isn't depleted and so forth. One of the things, there's a general discussion about improper payments as one of the goals that you have, mitigating against improper payments. So the reason for my inquiry about improper payments is this. Congress basically, if you look out over these different things that we've done over the past few months, we've got a highway trust fund that's going broke. We've got this, that, and the other thing. We had the SGR. Congress is basically grubbing around in the forest looking for truffles and trying to come up with a bushel of money to pay for these things. And yet the amount of money that's going out the door in improper payments just literally, at our hearing, it just took our breath away. You do a back-of-the-napkin calculation on this, and it's $1 billion a week. And the cumulative nature of this is just incredible. What insight would you have for us on the improper payment side in particular? Because the interesting thing is, there's obviously nobody that's defending the status quo. It's not a partisan issue. It's not a philosophical issue. It's not a geographic issue. It's just a common sense thing where we should all agree that payments should be proper, and if they are proper, we're going to save a fortune. What insight would you have for the committee as we venture out into this, particularly in the improper payment arena?
Right, and I just want to preface, I'm probably not the fraud guy that you want to answer this question. The commission tends to think of payment policy, looks at distortions, tries to stop, bad practices, but detecting fraud is kind of a different operation. So the first thing I would say about the size of the number, and in no way am I trying to defend anybody or anything, is, when I've gotten close to this issue a couple times in my life and not close enough and not really versed in it, there is this difference between fraud and catching fraud and documentation of a service. So a service was provided, it's a legitimate provider, but someone takes it apart and says, you didn't provide the right piece of information, just the. And I don't know that that's 12% versus point, whatever you said.
I take your point. And just parenthetically, here's part of the problem with CMS. They can't tell you the difference.
And that's why every time I get close to this, my head pretty much explodes. And so I'm probably not the right person to do this. But the thing that I would say, there are, there is this distinction between fraud, outright fraud, and fraud is complicated because people are actively trying to avoid detection, and I think that makes it hard. There is a cost of detecting it and a cost to payment ratio, although those are generally pretty positive, and I've seen numbers like that. The other thing, which is just an off comment I'll say out loud, I think some of these data releases where you begin to just kind of look at what the raw data says, has driven CMS and some of the other program integrity folks in directions that they probably wouldn't have otherwise seen. Individual sets of providers who come out at the top of the heap and are just pulling reimbursements that are just unbelievable. I think those kinds of things, those public releases of data, can also help almost from a crowdsourcing point of view to get other eyes on the problem.
So a sunshine policy, I mean, that sort of
Yeah,
disinfectant theory.
my sense is those things have driven people into identifying providers that had huge drug spends, huge Part B spends, that type of thing.
Okay,
But
Well-
I don't know this issue real deep. I understand what you're trying to ask, but
okay, thank you, yield back.
Thank you. Ms. Black, you're recognized.
Thank you, Mr. Chairman, and thank you for being here, Dr. Miller. Very interesting discussion today. I want to ask you about the Medicare Hospital Area Wage Index, which is supposed to ensure that Medicare hospital payments reflect the geographic differences in wages. I have concerns that many have raised over the years that the Area Wage Index is neither accurate nor fair. The fact is that around 1/3 of all hospitals receive exceptions to the Area Wage Index, shows that the system is not working. I'm even more concerned about the adverse impact that the current system is having on hospitals in Tennessee in particular and in the South, across the South, which have seen their area wage index levels rapidly decreasing over the years, while the area wage index levels in other states have been increasing. So Tennessee hospitals are being penalized because they have experienced an increase in costs, including wages over the years, but these increases have not been quite as high as the hospitals in other states where with wage index levels. It's simply unfair. I mean, they've done a good job in keeping costs down, but they're being actually punished for that. So back in 2007, MedPAC actually recommended that Congress repeal the area wage index. And is this still MedPAC's recommendation that Congress would repeal this wage index?
I got to tell you, I've been tearing up through this whole thing because people have kind of forgotten that idea. And the commission did make a set of recommendations. We do understand what you're saying and the issues that are being raised there. And we made that recommendation several years ago. And the fundamental, there's a number of things that are going on in it. But to get to the heart of your question, what's going on is we would move the wage index system off of a hospital reported wage and base it more on area wages or wages in the area for the labor that hospitals, offices, post-acute care providers are drawing. And that may sound like a big technical thing, but what it actually does is if a hospital decides that it happens to be flush and it raises its wages, all other things being equal, the wage index relative to other hospitals goes down because it's done across hospitals. Whereas we think it would be a lot fair to hospitals and other providers to base it on the wages in the area, which are much less sensitive to an individual hospital's behaviors, and we think that would bring some greater equity and address some of the issues that you're raising. There's a whole set of other things, which I won't make you crazy with, that we also recommended at the same time. But yes, that is our policy. We did recommend that change. We think it addresses at least some of the things that you're raising.
I know that was your recommendation back in 2007. Is MedPAC doing anything now to update that recommendation?
We can go through and update the analysis again, but the principles still stand. And I mean, bluntly, this requires the Congress to take action.
Okay.
And you know the dynamics here. I mean, this means some hospital,
That's right.
and that's the issue.
There will always be winners and losers, but when we look at what's happening in Tennessee, it really is an unfair system
And
for our reimbursements. Thank you, Mr. Chairman. I yield back.
Thank you. Ms. Jenkins, you're recognized.
Thank you, Mr. Chairman, for holding the hearing. Thank you, Mr. Miller, for joining us. I want to return to a discussion Congressman Smith started with you and discuss the issue of rural hospitals and some of the closures. MedPAC's March 2015 report addresses the rural hospital closure crisis and finds that rural hospitals represented 44% of all closures. The report finds that the closed hospitals are an average of 21 miles to the next nearest hospital, yet the report does not specifically address the issue of access to care in rural America. My congressional district has a number of these rural hospitals, and the state of Kansas has 83 critical access hospitals, more than any other. These hospitals provide excellent care to my constituents, and without them, my constituents would lose local access to care. When a patient has a heart attack, 21 additional miles of travel makes a difference. So my question is, has MedPAC considered the impact of access to care for rural Americans if and when these necessary safety net providers close?
So, I mean, my answer would be yes. Each year we assess access, quality, capital markets, costs and payments, and a number of factors in setting an update payment for the hospitals. And I can't remember if you were here when I was talking to Mr. Kind. The commission for the last couple of years has made positive payment updates for hospitals the last couple of years. Over 10 years or longer even, the commission has made recommendations with respect to rural payment that have increased payments to rural hospitals trying to address some of the issues that you raised. Now, all that said, I also want to say something else, which is in 2012, the commission did, and this was an exchange I believe I had with Mr. Smith, which was when you think about the supports, think about, how, and particularly the Congress is always working with a limited dollar, think about where that dollar is going to make the greatest difference. If you just say all increases to all rural, you're increasing payments for a hospital that sits right next door to, an urban area and a hospital that's 50, miles out on a hilltop. And so there are other ways to think about how the support is provided. And the other thing I think is just a fact of life, and it's for urban and rural hospitals, but to Mr. Smith's point and to your point, it can mean a lot more in a rural area, is if admissions continue to fall, these hospitals, are urban and rural, are going to have to rethink their mission. And an idea that seems to be floating around some of the urban or rural areas, that I've talked to people about is the notion of whether is it a full inpatient hospital that you need at that point, or do you need something more like an emergency room, urgent care type of thing? Because your point is a heart attack to go 21 miles or 20 more miles. I get your point, but what about a routine inpatient hospital service if in fact the admissions are declining? It is going to be struggle for hospitals, and particularly for rural areas, to support hospitals if admissions continue to decline.
Okay, I agree. Another study I saw from the National Rural Health Association, it reports that 283 additional rural hospitals are on the brink of closure, just shutting their doors. And this means, for these communities, they're not going to have the comprehensive local care that they need to survive. And of course, I think you understand when rural hospitals close, there's a domino effect. And employers are affected, communities, families, and the like. Just quickly, where are folks that call rural America home, receive needed health care? Where are they supposed to receive the needed health care if we see these rural hospitals closing?
I mean, I think it goes back to a point that I was making a minute ago, which is, again, how many fully comprehensive hospitals do you need for any given set of miles? I absolutely agree that you need some set of comprehensive care, but if we are supporting hospitals that are in rural areas that are very close to one another, and a question for the Congress, particularly with a limited dollar, is if there was a consolidation there, one hospital, it might be more financially viable, it might have higher quality, and it could be that we need to have these conversations about a different community saying, okay, they'll have an emergency facility, and this you'll have some consolidation for the hospital, and then an emergency facility to serve where you don't have a full hospital. Sorry.
Well, thank you, Ms. Jenkins. Ms. Noem, you're recognized.
Thank you, Mr. Chairman, and thank you for allowing me to be a part of this committee hearing today. I appreciate the ability to sit at the dais. Mr. Miller, I'm from South Dakota, so home of where the deer and antelope play, and it's a long ways to drive anywhere. We've had many consolidations already, but yet it's still a struggle for our people to get access. So I wanted to visit with you a little bit about the unique challenges that some of our rural providers face. And in your testimony, you stated that the last time MedPAC looked at rural Medicare beneficiaries' access to care, you found that the mix of payment adjustments for rural providers was incoherent and that it lacks a common framework. So in South Dakota, the providers that I meet with, they would agree with you. They tell me that they're forced to chase after dollars many times using a bizarre mix of adjusters and add-ons, which only adds to their administrative burdens. And to make matters worse, CMS often carves rural providers out of payment reforms, leaving them behind. So as the committee considers payment reform, can you suggest how we can improve the situation for rural providers?
Okay, I mean, we're having a theoretical or principle conversation. Again,
Absolutely.
focus your dollar first and foremost on isolated low volume, okay? Because isolated means there's no other alternative. Low volume means I can't support my costs. And so, if there's a dollar the Congress has, that first dollar should go to those types of facilities. I hate to keep harping on this. One that's right next door to an urban area, maybe the need is not as great. And I have to tell you, my rural commissioners, when we went through this, and I don't want you to think we don't look at rural every year. We just did a comprehensive thing in 2012. I mean, the rural commissioners were saying rural isn't rural. It differs depending on how far and how frontier you get. A second principle that the commission talked about was the notion that you can provide supports, but you can either do it open-ended or in a fixed way. If you provide an open-ended support, you're probably giving them, and there's evidence of this, that costs go up. And so then your supports have to chase that cost over time. If you give a fixed support, the provider continues to have some pressure to contain their costs. So we would say, think about that. It gets into individual measures. The empirical basis for some of the adjustments is questionable and gets into a little bit more technical conversation, but there are things where the analysis would say this is how much support you should give and there's this much, and you get kind of funny distortions or people chasing what you said, because I've talked to rural people and they say the same thing that you're saying. On the quality front, there is a dilemma, and I think that's what you meant by leaving them out of reform, or at least part of it, is they can't play as much in the quality. And this is a dilemma in the sense that if you have a small n, it's hard to get an accurate measure. You get real noisy quality results. I mean, the commission has talked about accumulating multiple years of data. If rural providers are willing to be treated as a group, you can consolidate them and say, judge us on our net performance. There's ways to try and jump those kinds of fences.
Have you come to a conclusion on that? Do you think that would be accurate, or have you floated that idea to rural providers to see if they would consider?
We have certainly discussed that in principle in our reports. I mean, obviously, when somebody comes to you and says, okay, it's the two of us, it's hard, for us to say that one is noisy, that one isn't noisy. We'd have to see the thing to know. And actually, there's also some people who are trying to organize networks of rural providers in ACOs as well.
Okay.
Again, kind of accumulating a number of rural providers.
Okay. Thank you. I yield back, Mr. Chairman.
Thank you, Ms. Snow. Mr. Crowley, you're recognized.
Thank you, Mr. Chairman, and thank you for allowing me to sit in on your committee hearing today. I know the subcommittee is looking primarily at hospital policy issues, and so I'm glad to have the opportunity to participate in the discussion. Mr. Miller, as you know, I represent part of New York City, home to a number of world-class medical institutions, from teaching hospitals to cancer centers to medical schools. So I've had many discussions with healthcare systems on how much they rely on Medicare payments just to be able to provide care to their populations. Today I want to focus on the issue of graduate medical education, or GME. To start, there's a point that I want to make clear. Training our nation's doctors has long been a shared responsibility between individual teaching hospitals and the federal government. And that's because it's a shared benefit. The teaching hospitals may be the one receiving the payment to offset a portion of their costs, but it is the whole country that benefits from more well-trained doctors. Ensuring that our academic medical centers receive adequate funding through GME is not just an issue for that hospital, it's an issue for our entire nation. The doctors who train in New York, for example, go on to practice all over the country. And they practice in every specialty too, from primary care and family medicine to the most targeted specialties. So I really do think that the discussion of how we pay for graduate medical education can't just start and stop with dollars and cents at a single hospital. It has to consider the investment that we make in caring for our senior citizens and in our nation's entire health workforce. Part of that investment is also in the highly complex and costly patient care missions that teaching hospitals undertake. They run advanced trauma centers and burn units, and they see more complex patient cases. They treat patients with rare and difficult diseases like Ebola. And that helps train future doctors in all those areas. Graduate medical education payments were designed by Congress to reflect all these undertakings beyond just the explicit costs you may see on paper. And teaching hospitals will continue to take on new challenges. Mr. Miller, in your testimony, you say that to provide our healthcare delivery system, we need to, quote, ensure that our residency programs produce the providers and skills necessary to integrate care across settings, improve quality, and use resources efficiently. Well, from what I've seen, our teaching hospitals are tackling that challenge head on. One of the things we've strived to do with the Affordable Care Act, the permanent doc fix, and other initiatives is to highlight the importance of coordinated care, preventative care, and other quality measures. We all recognize that care does not just happen within the four walls of a hospital, and it shouldn't. Teaching hospitals are doing more to train residents in community care settings and to focus on giving residents the skills they need to provide exactly the kind of care that MedPAC and others have called for. And they have to use resources efficiently because they are getting hit with cuts from all sides. I would argue that a sufficient investment in GME, not cutting and redirecting funding away, is what enables hospitals to do all these things. Do you disagree? Why can't we accomplish these goals without cutting funding?
The commission has a policy on GME or a recommendation on GME that I can take you through. The commission's policy took a block of the current IME dollars and allocated them in a different way. It didn't reduce them. But it also would say, in response to at least some of the points that you're making, as it stands, this is what we're talking about, $3.5 billion. The accountability for that dollar doesn't exist. The notion that it's being devoted to teaching and training for a reformed delivery system or whatever the case may be. Currently, we have no accountability for it. It's just a dollar that flows into the hospital, can be used for anything. So I think we would agree in the sense of saying you take the dollars that exist, you allocate them differently, which I can take you through, and you target them to hospitals, and this is the part where you may disagree, but just to be clear, and other providers who are running graduate medical education programs that are more comprehensive in team-based care, evidence-based medicine, and also alternative sites of care where they're trained in addition to the hospital. But we didn't talk about eliminating the dollar.
I appreciate that, and I do appreciate accountability as well, and I think you appreciate the complexity in terms of the teaching of a modern doctor today. As a New Yorker, I think we can chew and walk gum at the same time. I think we can do more and do it better. I agree with you on that. I believe we need stronger investment in graduate medical education, like raising the outdated cap on the number of residents that Medicare supports. And I'm just finishing up, Mr. Chairman. I have a bill to do just that with my good friend and my colleague, Dr. Bustani, in a bipartisan way, and a large bipartisan support for that, Mr. Miller, as well. Mr. Chairman, I know you've talked about putting together legislation to help support our nation's hospitals, and I hope you will consider this issue as a priority to include. I also hope you will recognize the hurtful impact of cuts to GMA program, not only on the hospital that rely on this federal contribution, but on the doctors who train there, and the patients who will see throughout their careers. I look forward to working with you in the committee to ensure that we continue to provide needed funding to our nation's teaching hospitals. And with that, I yield back.
Thank you, Mr. Collins. Mr. Renacci, you're recognized.
Thank you, Mr. Chairman, and thank you as well for allowing me to be part of this committee hearing this morning. Dr. Miller, your testimony and the June MedPAC report raised some critical issues, especially as they relate to improving hospital payment policy. The ACA included a new program which is addressed in a report aimed at reducing unnecessary hospital readmissions. The program is known as the Hospital Readmission Reduction Program. The goal of this program is one that I and many of my colleagues support. In fact, it is estimated that nearly $18 billion per year is wasted on avoidable readmissions, $18 billion per year is wasted on avoidable admissions of Medicare patients alone. Reducing these preventable readmissions would reduce costs and improve outcomes. However, the implementation of this program has been problematic, especially for those hospitals serving low-income patients. Dr. Miller, can you explain the correlation between hospitals serving low-income patients and readmission penalties? Is there a direct correlation, in your opinion, and do you have some concerns?
Yeah, and we have some fixes as well. So there is a relationship. Depending on what you mean by direct, this is more of subtlety. There seems to be a critical mass. So you get more poor people. You don't see a lot of change in readmission rates. And then you hit a certain level of having poor people as a percentage of your hospital, and then you start to see higher readmission rates. There's a relationship. It's not directly one-to-one, but there is a relationship, and we've laid this out in the report, and we fundamentally agree with the statement that you're making. The commission ended up saying this, and what we ideally want, we've made some other recommendations to refine the measure. What we really want is we don't want the penalty dollar. We want the hospital to avoid the readmission. It's better for the patient. The program saves money by avoiding the readmission. The penalty is really just a motivation, and actually a very small amount of dollars are actually driving relative change, and so I'm hoping that this is headed in a positive direction. With respect to the proportion of poor people, this is what we would do. We would not adjust the measure. So if a hospital has a good or a bad readmission rate, that remains on paper because we think hospitals need to be focused on that. The public needs to be aware of it. Whether you're rich or poor, you should know what your readmission rate is in a given hospital that you're about to walk in the door. However, mitigate to some extent the effect of the penalty. And the way you do that is you say that the penalty will be mitigated based on how many proportions of poor people. And we would put hospitals in category and say lots of poor people, the penalty is not as heavy. Few poor people, the penalty is heavier. And then within any category, you have to outperform your colleagues. So if I'm a hospital with lots of poor people and I do well on readmissions, I am spurring other hospitals to improve their performance. So we would mitigate the effect, but we would do it through the penalty, not adjust the measure.
But you do agree then that hospitals that have these lower income patients inevitably are going to have these readmissions more than other hospitals. Correct?
Yes, but we also believe that there are hospitals out there with lots of poor people who have relatively low readmission rates, and change can occur, and we would mitigate the penalty to help them along. But yes, we agree with the statement you made.
All right. Well, I share your concerns that many of the hospitals, especially my district, that serve the most needy are being unfairly penalized under the hospital readmission reduction program. I have introduced H.R. 1343, the Establishing Beneficiary Equity in the Hospital Readmission Program, which would require risk adjustment for socioeconomic factors when calculating hospital penalties, ensuring these critical hospitals can continue to take care of the least among us without being penalized for doing so. And I thank you for your work MedPAC has done on this issue, and I yield the remainder of my time.
Thank you, Mr. Ornacey. As you've noticed, we've held a hearing on competition next week, focusing on rural disparities. We're going to be discussing GME and hospital payment reform in the hopes of bringing, through the fall, in the hopes of bringing some legislation to the floor, into the committee there. Today's hearing was very helpful and insightful as we go forward with that. So, Dr. Miller, thank you for your testimony. Appreciate your continued assistance. We'll need it. Getting answers to the questions were asked by those in the committee. And as a reminder, any member wishing to submit a question for the record will have 14 days to do so. And if any member does, Doctor, I ask that you respond writing in a timely manner, which I know you will. Again, thank you. With that, the committee is adjourned.